Good morning, good afternoon. Apologies for the delay in starting this session. My name is Ruby Fayose. I'm the RISE Technical Director focusing on global HIV programming and the Deputy Director of the Clinical and Training Unit at ICAP, Columbia University Mailman School of Public Health, New York. Next slide, please. I'd like to cover a few housekeeping issues. We're going to have translation. Hopefully our translators will be able to join the webinar shortly. But if you look at the bottom of your screen, you will see an icon which says interpreter. Please use that to select your language of choice. All mics will be on mute during the presentation. So please type your questions into the Q&A box, not the chat box, and we will address all the questions after the presentations. We will also make sure that the slides and recordings will be available at the end of the webinar. Next slide, please. So I'd just like to give you a brief overview about the RISE consortium. So RISE, which is Reaching Impact, Saturation, and Epidemic Control, is a 5-year global funded project by PEPFAR and the U.S. Agency for International Development. RISE works with countries to achieve a shared vision of attaining and maintaining epidemic control with stronger local partners capable of managing and achieving results through sustainable, self-reliant, and resilient health systems. The project supports countries to respond to the HIV and COVID-19 pandemics, providing technical assistance, service delivery, research, and cross-cutting health systems to support critical HIV and COVID pandemic priorities in country. Since the program began in April 2019, RISE has supported 22 countries with HIV and/or COVID programming. The RISE consortium is led by JPIGO, the Prime, in close collaboration with ICAP at Columbia University, MSH, MAN Global Health, ANOVA, and other global and regional partners. Next slide, please. So this is just a quick overview of the session we have planned for you today, and it's definitely going to be very interesting. We have 2 great speakers from the RISE project in Nigeria. The first speaker, Dr. Remi Oladigbolu, will talk about advanced HIV disease innovations and lessons learned from the RISE project, after which we'll take a couple of questions. And then our second presenter, Adejo-Ogiri, will also talk to us about virtually accelerating linkage of men to reframed HIV services, VALOR, in Nigeria, after which we'll also take some more questions, and then we'll open it up for a discussion. Next slide, please. So our first speaker is Dr. Remi Oladigbolu. He is the Care and Treatment Advisor at ICAP, Columbia University, and currently serves as the Acting Care and Treatment Lead Advisor for the RISE Nigeria project. Dr. Remi is a public health physician and a fellow of the West African College of Physicians in Community Medicine, and has over 30 years of experience in public health. He holds a medical degree from the University of Ibadan in Oyo State, Nigeria, and also a postgraduate diploma in management and master's in public health from the Usmanu Dofio University in Sokoto, Nigeria. Our second speaker, Ms. Adejo-Ogiri, is the Gender Technical Advisor with JPIGO Nigeria, an affiliate of Johns Hopkins University. She provides gender technical support to the RISE Nigeria project. Ehi provides expertise and technical support in gender mainstreaming and integration with core skills in health system strengthening and health promotion. She holds a BSc in Public Health Education from Babcock University in Ogun State, Nigeria, and MS in Health Promotion and Public Health from Canterbury Christ Church University in England. She also holds certificates in gender and sexual diversity from USAID, leadership and management in health by the University of Washington, gender, sexual, and reproductive health by Johns Hopkins Bloomberg School of Public Health. So I'd like to turn it over to Dr. Remi to start us off with the first presentation.
Okay, thank you so much, Dr. Ruby. This is Remi Oladigbolu, speaking from Uyo, Akwa Ibom State, Nigeria. And I'll be presenting advanced HIV disease, innovations and lessons learned from the RISE project. Please, the next slide. So a brief overview of the RISE project. It's a 5-year USAID funded project that commenced implementation in 2019, and we're currently in our 4th year of implementation. And the goal is to address the challenges of HIV in Nigeria and to reduce the burden of unmet needs. RISE Nigeria Consortium of Partners is led by the PIGL as prime and ICAP at Columbia University as core partners. As of September 2022, we're in 5 states, namely Adamawa, Akwa Ibom, Cross River, Niger, and Taraba State. And currently, we've seeded up Niger State and Adamawa State. We support Adamawa, Akwa Ibom State, Cross River, and Taraba State. Our HIV strategic objectives include HIV testing and counseling services. Objective 2, HIV care and treatment services. 3, viral load services. 4, robust monitoring, evaluation, and learning system. And the 5th is to contribute to the health system strengthening. Next slide. So the outline of this presentation includes a background of AHD and a global perspective on AHD in Nigeria and its implementation through the RISE projects, strategies and best practices on AHD, and I'll conclude with challenges and recommendations. Next slide. The Joint United Nations Programs on HIV and AIDS, UNAIDS Global Update for 2022 reported that the progress to end HIV/AIDS epidemic by 2030 is stalling. Although new HIV infection decreased by 32% between 2010 and 2020, there were approximately 1.5 million new HIV infections in 2021, which is 1 million more than the global targets. AIDS-related deaths have plateaued. In 2021, there were 680,000 AIDS-related deaths, with tuberculosis and cryptococcal meningitis accounting for majority of these deaths. Children less than 14 years are also disproportionately affected. They account for only 4% of people living with HIV, but 15% of all AIDS-related deaths. And over the past 2.5 years, the colliding AIDS and COVID-19 pandemic, along with economic and humanitarian crisis, have placed the global HIV response under increasing threats. Next slide. The dramatic scale-up of antiretroviral therapy acts from 2000 resulted in rapid decline in AIDS-related deaths. However, the UNAIDS 2022 global updates reported that 1 person died from AIDS-related every minute in 2021, despite effective HIV treatment and tools to prevent, detect, and treat opportunistic infections. And if the current trends continue, almost 500,000 will die from AIDS-related illness in 2025, which is off the global target of 250,000. Next slide. So similar to adults, the rate of AIDS-related deaths has declined in children and adolescents. Children saw the steepest decline between 2010 and 2022 at 60% compared to 37% among adolescents. And in both groups, there have been little improvement in mortality since 2017. Next slide. A study by Lam and colleagues in 2020 revealed that the proportion of people living with HIV presenting with CD4 count less than 200 remains high and fairly constant since 2020. since 2012. Next slide. What is advanced HIV disease? The World Health Organization defined AHD as having a CD4 count of less than 200 for adults, adolescents, and children above 5 years old. And children 5 years and below with HIV are considered to have advanced HIV disease, since 80% of them have evidence of immunosuppression at ART initiation. However, if a child is above 2 years old and is on at least 1 month on ART and is established in care, they should not be considered to have AHD. Next slide. So the major causes of opportunistic infection in patients with AHD are tuberculosis, cryptococcal meningitis, pneumocystis jirovecii pneumonia, and severe bacterial infection, with tuberculosis being the commonest, and the second is cryptococcal meningitis. And some of these opportunistic infections can be prevented by providing prophylaxis, like tuberculosis prevention therapy, and cotrimoxazole, and also preemptive therapy for cryptococcal disease. Next slide. In Nigeria, in spite of increasing number of people living with HIV on treatment, the estimated number of AIDS-related deaths has plateaued. In 2018, close to 32% of people living with HIV had CD4 count less than 200 at ART initiation. And similar data from 6 high-volume facilities in the country suggest that the burden of AHD ranges from 16 to 50%, buttressing the need for an active surveillance on AHD that will need seamless, systematic collection, analysis, and interpretation of AHD data, essential for planning, implementation, and evaluation of public health evidence-based practices for prompt decision-making. Next slide. The Nigeria AIDS and STI Control Program established the AHD Working Group in 2019 to provide active surveillance for AHD in the country. And they developed AHD package of care and training modules, which were implemented in 2 phases. First phase had 28 high-volume facilities across 4 states in the country that included Akwa Ibom State. Others were Lagos State, Anambra State, and Rivers State, with General Hospital Ikot-Ekpene in Akwa Ibom, one of our flagship sites, part of this first phase. And the second phase had a national scale-up of AHD implementation. Next slide. Nigeria adopted the World Health Organization AHD package of care. The WHO guidelines is on the left, while the national guideline is on the right. And the difference being that the CD4 benchmark of less than 200 as in the national guideline compared to less than 100 in the WHO guideline for those eligible for TB, lipoarabinumab, LAM, and cryptococcal antigen screening. Next slide. The World Health Organization rolled out AHD package of care to reduce morbidity and mortality among children living with HIV, and this is called Stop AIDS. S, to screen for opportunistic infection. C, to treat the identified opportunistic infection. And O, to optimize those without the opportunistic infection with antiretroviral therapy within 7 days. And P, to prevent opportunistic infection. And RISE Nigeria has implemented RISE Nigeria has implemented this, including improving tuberculosis diagnosis for children with the use of TB LAM and stool for gene experts, ensuring that all children are on optimal antiretroviral screening for malnutrition, and linking them to community resources like the orphan and vulnerable children partner for nutritional support. And the support to prevent bacterial infection include isoniazid against tuberculosis, cotrimoxazole against pneumocystis jirovecii pneumonia, and vaccination against vaccine-preventable diseases. Next slide. Who should be screened for AHD? 1, the newly diagnosed with HIV. 2, recipient of care who have interrupted treatment for over a year. 3, ROCs with treatment failure. and 4 ROCs with detectable viral load for over a year. Next slide. Cryptococcal meningitis is the second most common AHD, but accounts for the highest AHD-related deaths. Studies have reported that 70% of ROCs that receive little or no treatment for cryptococcal meningitis are likely to die. Furthermore, up to 30 to 40% of those treated are still likely to die. Liposomal amphotericin B is the most potent drug for the treatment of cryptococcal meningitis given an induction phase. And the 2022 WHO guideline on cryptococcal meningitis recommends high and single dose of liposomal amphotericin B with flucytosine and fluconazole for 2 weeks against 1 week regimen of liposomal amphotericin B with 5-flucytosine and 1 week of fluconazole during the induction phase. And this regimen was shown to be non-inferior to the standard of care and has better safety profile, requires less monitoring, and potential for reduced length of hospital stay. Next slide. AHD implementation within the RISE Nigeria project. Next slide. So as of September 2022, we supported 5 states, and we also support 122 facilities. 48 of them are offsites and 74 are spoke seven. Currently, I was seated of Niger and Taraba State. We support Akwa Ibom, Cross River, and Taraba States, where we support 101 facilities. 31 are hub sites and 70 are spoke sites. Next slide. And these are the states. Akwa Ibom being the epicenter for HIV, with 5.5% of the reproductive population living with the disease, and Niger State having 0.9% of the reproductive age group living with HIV. Next slide. So what are our strategies and best practices on AHD implementation? First, we set up AHD team among our government of Nigerian staff and RISE ad hoc staff. So among the government of Nigerian staff, AHD comprised of an ART coordinator, which has a clinician, a nurse, a lab scientist, a pharmacist, and an M&E officer. And in addition to a counselor tester and test manager and data entry clerk, we have such in the ad hoc staff. And we've had several trainings to build a capacity on AHD, first by having in-person training, and we've also had several echo sessions on AHD implementation, and we've also had routine supportive supervisory visits to support the theme on AHD implementation. We've also used hub and spoke model to link facilities without the capacity to provide AHD services, while also ensuring the integration of AHD quantification, drug quantification, with our overall ARV commodities management. We've also had a meeting where we shared learnings and best practice among our team. We report AHD performance, not just to the mission, USAID, but government of Nigeria, while also strengthening our referral mechanism in a community by leveraging on a community ART team, that's the tactical epidemic control team at the LGA, to ensure that every newly identified client at the community receive the 6 minimum package of care. Next slide. Namely, retesting for verification. Second, a clinical review where a tech team nurse or a doctor uses adult or pediatric initial clinical evaluation to review this client, and also to have CD4 count testing done to identify those with advanced HIV disease, biometric capture, screening for tuberculosis, and COVID-19 vaccination. We vaccinate our recipients of care using several methods that are not limited to our adult staff serving as vaccine ambassador, where we'll ensure that they are vaccinated, but also be able to use other motivational behavioral strategies that include motivational interview, presumptive communication, and why we ensure they also dispel disinformation and misinformation. Next slide. The minimum package of care for recipients of care with AHD includes the screening for tuberculosis using TB, liporabinomammal, and to cryptococcal antigen screening, where we have the serum to screen for cryptococcal meningitis, and the confirmation is done following a CSF cryptococcal antigen analysis. Third is to give cotrimosadol prophylaxis against opportunistic infection. And for those without active TB, to be placed on tuberculosis preventive treatment, includes isoniazid and currently the 3-HP. 5 is to the case management to support adherence to antiretroviral treatment by ensuring that every recipient of care is assigned a case manager who serves as a treatment support specialist and being able to use other strategies that include CBAS, cognitive intervention, behavioral interventions, affective intervention, and structural intervention to scale up their self-care. Next slide. Facility level in AAG strategies include prompt forecasting of AAG commodity to avoid stockouts, optimize AAG screening for virally unsuppressed clients and for clients that were flagged back for having been interrupted their treatment for over a year. We also strengthen cold chain for amphotericin-B storage and transportation, and the provision of opportunistic infection that includes cotrimoxazole, isoniazid, and fluconazole. Next slide. Our point of care tool that we use for AAG screening and diagnosis on the RISE project include Omega VCTech CD4 advanced disease that is highly sensitive, Abbott determined TB LAMP that is highly specific, and cryptococcal antigen lateral flow assay that also has high sensitivity and specificity. Next slide. Next slide. So we've shared several job aids to our team, our AAG team, to guide and support them on the AHD, VCTech, TB LAMP, and even the national guideline. Next slide. So the combined chart shows the proportion of newly diagnosed screened for AHD. The chart on the left shows that among the newly diagnosed, 38 were screened for AHD. The lowest was in Q1 at 5%, and the highest was in Q3 at 71%. And this was due to stockouts of VCTech. And among those screened for AHD, 17% has CD4 count less than 200. The lowest was in Q2 at 12%, and the highest in Q3 at 21%. The 17% prevalence of AAG on the RISE project is significantly lower than 71% reported in a recent study by Benzakri et al. From Senegal, a country within the West Africa region. Next slide. So the bar chart on the left shows the proportion of newly identified people living with HIV with CD4 count less than 200 who received TB LAMP test. Overall, 62% of persons with AAG received TB LAMP tests. The graph on the right shows the TB diagnostic cascade. And overall, over 49% of recipients of care who received TB LAMP tests had a positive result and were diagnosed with TB, and all of them were started on tuberculosis treatment. Next slide. The component bar chart on the left shows the proportion of newly identified recipients of care that were screened for cryptococcal meningitis using serum cryptococcal antigen, as CRAC. Overall, about 30% of recipients of care with AHD received CRAC tests. The graph on the right shows the cryptococcal management diagnostic cascade. Overall, a third, that is 5 out of 15, who were positive for serum CRAC had a cerebrospinal fluid CRAC. And 3 of them, with 60%, were positive and subsequently treated for cryptococcal meningitis. Next slide. Regarding our M&E, our monitoring and evaluation system for AAG, we had joint AAG data reporting and validation with Nigerian AIDS and STI control program, including the states and child. We've also had a monthly AHD harmonization meeting with our strategic information team for conference on data. Also had high frequency reporting of AHG services on LAMIs across all facilities at hub and spoke, and bi-weekly presentation on AHG across the RISE state, discussing around the data and sharing best practices to close the gaps. Next slide. So what are challenges and mitigation plans? First, pill burden. Only 100 milligram of fluconazole is available. And this implies that recipients of care that are particularly on treatment for critical meningitis can be on tablets as high as 15 tablets per day. So we'll solicit for support for higher doses of fluconazole to limit pill burden, while we continue to support our recipients on care on adherence needed for better treatment. 2, suboptimal supply of AHG materials and consumables. We've had stock out of AHG commodities for months. Although I'm glad to say that we've received new stocks of TB lamp and crack tests. However, we're still yet to receive Visitec. But I'm aware that the Visitec is available in country, so it would be nice to have prompt forecasting of AHG commodities and instituting centralized quantification of AHG to increase pull effects. 3 is the supply of short-dated AHG screening kit that includes Visitec, TB lamp, and crack tests. And the need to continue to engage with our state logistic management coordinating team with AHG data to facilitate the redistribution of these commodities cannot be overemphasized. 4th is the underreporting of AHG data on EMR. It's key to improve data quality across our patient monitoring and management, program monitoring and evaluation, and our electronic record. And for this data to also be disaggregated by age and sex. Next slide. Another challenge is lack of laboratory support to monitor blood chemistries and hematology for clients on liposoma and hepatitis B. Also, lack of support for clients with HIV and high cost of inpatient care. High cost of inpatient care for clients managed for AHG. And the need to provide financial support that covers laboratory tests like electrolyte urea and creatinine, full blood counts, and the cost of admission cannot be emphasized. Also, suboptimal supply of spinal needle to perform lumbar puncture for eligible AHG clients. And it's key to procure lumbar puncture sets to support HOPs with positive serum crack tests for CSF analysis. Another challenge is lack of outcome research on AHG for better decision making. Funding is needed for primary data analysis on AHG implementation in the RISE project. And finally, challenges with equipment maintenance. And it's key that the support for CD4 equipment maintenance at the hub site is key to scale up access to comprehensive AHG services. Next slide. AHG success story from the RISE projects. Next slide. So it's a success story, the RISE project, and the title is Improving Quality of Services for Recipients of Care through Advanced HIV Disease Implementation. Mr. X, a motorcyclist and known recipient of care for over 2 years, was brought to the hospital by his wife unconscious, and was said to have had a recurrent throbbing headache for a week, and episode of convulsion, which was managed traditionally with no known previous history of this complaint. He was diagnosed with advanced HIV disease with CD4 count less than 200, and further investigation revealed that he also had tuberculosis, and the serum meningitis was positive, while the CSF analysis for meningitis was negative. He was immediately commenced on preventive therapy for cryptococcal meningitis and treated for tuberculosis. He regained consciousness after some days and was discharged. He was thereafter placed on intensive adherence monitoring. 6 months afterwards, he came with his wife for follow-up clinic, and I was smiling. The CD4 count has increased to above 200, and the repeat serum crack was negative. He had undergone several sessions of behavioral change using stage of change model to optimize his self-care. And he said, I quote, "I am very happy how you people have been taking care of me. That time I thought I was going to die. I like the way doctors call and send me text messages every week to take my medication. I will never allow this type of thing happen to me again by taking my drugs every day." RISE Nigeria acknowledges that offering quality and comprehensive AAG screening for newly identified cases of loss to follow up and those with persistent viremia will further reduce deaths among HIV and AIDS and support the achievement of HIV epidemic control within the nearest future. Thank you. Next slide. Thank you.
Thank you very much, Dr. Oladigbolu, for that excellent presentation on improving services for recipients of care with advanced HIV disease. So we have our interpreters present now. If you look at the bottom of your screen and you see the globe button, please click on it and choose your language of preference. There's interpretation available in Spanish, in French, and Portuguese. So we have a couple of questions that have come in, and for those who just joined while the presentation was ongoing, please type your questions into the Q&A box, not the chat box, into the Q&A box, and we will have them answered. So the first question is from Dr. Diana Mukina, and she's asking, is the cryptococcal antigen test done irrespective of the baseline CD4 count? And is this only through point of care testing, or there are some tests that can be done through the lab? The second question she's also asking is, you shared that you're reporting to the government of Nigeria on AHD. What are these indicators that are being reported to the government of Nigeria? And then finally, should like you to speak a little more about the hub and spoke module used for managing recipients of care with advanced HIV disease.
Okay, thank you so much, Dr. Ruby, and thank you for the questions as well. Also, regarding the first question, serum cryptococcal antigen screening is not the first test done. The first test in the cascade for AHD is to identify, to screen for AHD by using either VCTech or the use of the point of care at the facility, and that includes BD-Fast Phase-2. So when the client has CD4 count less than 200, that client has advanced HIV disease, and after which other tests are done to screen for tuberculosis, that's TB-LAM, and also to screen for cryptococcal antigens, starting with serum cryptococcal antigen testing. And for those who are now positive, they are now subsequently tested using the CSF cryptococcal antigen, which is a confirmation of the infection. So the second question on the data we report to government of Nigeria, we report the AAG cascade to government of Nigeria, and that includes the eligible client as a recipient of care newly diagnosed, the number of recipients of care diagnosed for HIV, the number that were screened for AHD using either VCTech or the other point of care at the facility, and the number among those that were AHD with CD4 count less than 200, how many of them were screened using TB-LAM? And for those that are even positive for TB-LAM as well, too, how many of them had a gene expert test? And for those that are still also positive for AHD, how many of them were screened using for critical meningitis using serum PrAG tests, and for those that are positive with serum PrAG tests, how many of them had a confirmatory test using CSF PrAG tests? And how many were of this positive find? How many were comments on either tuberculosis or meningitis? So these are part of the cascade of care on AAG that I share with the government of Nigeria staff. And on the hub and spoke, so the AAG package of care we implement on the RISE project, it's actually based on 4 different attributes. And that implies that a facility is categorized as either a hub or a spoke based on this package of care. Number 1 is screening and diagnosis. Screening and diagnosis, ability to screen for AHD and also screen for TB and make a diagnosis of not just TB for critical meningitis. 2 is prophylaxis for tuberculosis and preemptive care for coccal antigen. That's 2. The 3rd is ART initiation, while the 4th is adaptive adherence supports. So our facilities are actually categorized as hub and spoke based on the availability of this, particularly based on the availability of HR and the commodity to be able to screen and diagnose, screen for AHD and subsequently make a diagnosis of tuberculosis and critical meningitis. Because we have several facilities. Our facilities include primary health facilities, secondary health facilities, tertiary health facilities, and even including a quaternary facility. So most primary health facilities and even other spokes at the community, like the community ART team, we may not have the infrastructure and also the HR needed to perform either a lumbar puncture test or the availability of a cold chain to be able to store the liposomal amphotericin B that needs to be kept in a room temperature less than 25 degrees, and also should not be frozen, and other technicalities that is needed. So these facilities are actually categorized as spoke. So we have this hub and spoke model where the hub, preferably at a general hospital, a tertiary hospital, or quaternary hospital that can actually give the full cascade of care. That is 4: screening, diagnosis, prophylaxis, preemptive therapy, ART initiation, and adaptive care. While other facilities are categorized as spokes based on the availability of HR, based on the availability of opportunistic infection drugs, based on the availability of VCTech and others as well. So the essence of this is to ensure seamless access of recipient of care to AHD implementation. Thank you, and over.
Thanks, Dr. Remi. So we have several other questions that have come in through the Q&A. There's one question around commodity management. Apart from strengthening the quantification of commodities, what other strategies were put in place to address stockouts, especially in CD4 cartridges and OI drugs?
Okay, so seamless availability of AAG commodity is integral for its implementation on the RISE project. So we ensured easy access and availability of this commodity by working with our supply chain. Remember that I talked about that within the AAG team is a supply chain, a pharmacy. The pharmacy liaises with a supply chain lead on the RISE project. We also engage the supply chain lead to ensure he or she works in collaboration with the state logistic management unit within our state on this availability of stock, the stock on hand, and when the next cycle of restocking to just ensure seamless access. These are one of those several strategies we've actually done. However, what has actually resulted in the stock out over the month before we got the new stock with the fact that these commodities were not even available in country. But currently, we have been restocked of the liposoma amphotericin B, TB lamb, and we're aware that Visitech is in country, so probably before the end of the week, or maximum probably within the next 2 weeks, we should have Visitech available for distribution. Thank you.
Thanks, Dr. Remi. So another question that has come in is around the frequency of CD4 count being done as per national guidelines. And then maybe you can also answer a follow-up question about TB, which is also asking, what do you make of the high TB yield, 49% amongst the recipients of care who received a urinary TB lamb test in the RISE project?
Okay, so thank you so much for the question. Also, regarding the frequency of CD4 counts on AIDS implementation, the RISE project. CD4 test is done at baseline to screen for AAG. So that's one. And if the client is has CD4 count less than 200, as AAG, the client is further screened for tuberculosis and curricular meningitis. And it's expected for a client that has tuberculosis is in place on medication. But for those that have curricular meningitis, they are commenced on induction phase that starts for 2 weeks. They are now placed on the consolidation phase and maintenance phase. And the CD4 count is done for them after a year of being in the maintenance phase. And for those that have CD4 count above 200, and their viral load significantly suppressed, clients their medication is actually stopped and they can continue with other medications. And I think I didn't get the other question. Okay, I think tuberculosis, I didn't get that. Okay, so for tuberculosis, we had 49% of them that were positive for tuberculosis, and this is more or less, we've actually looked into this data as well. And remember, I made mention of short-dated kits because this yield of 49% is high, so perhaps it could be false positive error because of the kits that were short-dated, and that was why we had to engage our state logistic management unit to ensure the redistribution of these kits to facilities that need them, and to avert being either to avert expiration or to avert the errors we have. So more or less, it's probably as a result of the short-dated kits that we had. Thank you.
Okay, I will have us take a couple more questions and then we'll move to the next presentation. And if there's time, we'll come back and answer the rest of the questions. So someone is asking about the viremia clinics. Could you explain what this means? And then they're also asking that for recipients of care who are unable to afford the hospitalization for treatment of advanced HIV disease, what kind of resources do you have for them while they're on admission, since the cost of admission could be very high given all the testing that they need done?
Okay, thank you very much. The viremia clinic aims to ensure we render comprehensive enhanced adherence counseling care for our clients. The essence, the aim of HIV care and treatment is the attainment of viral suppression and, much importantly, undetected viremia. But for clients that had suspected treatment failure evidenced by a viral load above 1,000 copies per ml of plasma, they are enrolled into viremia clinic. And this Remi clinic can either be in person at the facility or can also be virtual, depending on the environment, on the security checks. And the aim is to ensure that this client is enrolled in EAC, like EAC 1, EAC 2, EAC 3, each lasting a month, and to address different issues mitigating against adherence and suppression for their care. So, and so the causes of the suspected treatment failure could be as a result of the patient factor, the medication factor, and other factors as well too. So we have teams that work together to support, particularly the case manager, to support these clients and see how best they can address issues resulting in the treatment failure. And for those that are found to, because after EAC 3, another viral load is done as post-EAC, and if this viral load is found to be suppressed, this client is further counseled on the need for them to be adherent, and they continue the current medication. However, for those that had still high viral load above 1,000, it's termed confirmed treatment failure. That client is switched from the regimen he or she is to a second-line regimen for better treatment outcome. Thank you.
Okay, the last question was around supporting recipients of care while they're on admission, given the fact that the cost associated with the hospitalization may be very high. And so what have you been able to do in the RISE project to help when recipients of care are on admission?
All right, so thank you so much. We've actually done a lot to support the recipients of care on admission. First, by having this collaboration with the facility, that's the facility AAG team, on how they can, because the client belongs to the facility, we just support on how they can actually support this client with the needed ancillary tests and for their care. Additionally, we've also been able to work in collaboration with NEC1, that's a network of people with HIV and AIDS, to provide support in this regard. Furthermore, we've also been able to work with a quaternary health facility, like that EBOM specialist, where we supported them with not only kit, but even lumbar puncture and the capacity for them to be able to get this test done at no cost for our clients. That's lumbar puncture and few other ancillary tests as well. So these are a couple of things we've actually done. So working together, working with the State Ministry of Health in seeing how best they can actually further support these clients in that care. Thank you.
Thank you very much, Dr. Remi, for that fantastic presentation, and thanks to the participants for all the great questions. We will come back to the rest of the questions that we haven't answered when we finish the second presentation. So I'm now going to call on Adejo-Ogiri to talk to us about virtually accelerating linkage of men to reframed HIV services in Nigeria.
Okay. Thank you. Good morning, good afternoon, and good evening, everyone. I am Adejo-Ogiri, and I'll be sharing our experience on RISE, implementing an innovative intervention called VALOR. Next slide, please. So we will be looking at what VALOR is during the pilot phase, what the theory of change is, the VALOR strategy, and then post-pilot, the results we've had, and then challenges and lessons learned. Next slide, please. So VALOR is an experimental initiative that came to fore in the light of COVID. This began as a pilot on virtually engaging men to HIV testing services. The VALOR concept came at a time also when the RISE team was looking for other ways to increase HTS testing and ART services amongst men, which stemmed out from a gap identified early on RISE, where we had less men coming out to test, less men knowing their status, being linked to care for those that have been identified positive and retained in care. So Valor focuses at examining, optimal ways to adopt and, deploy reframed empathy-powered social media messaging using virtual navigators with the hope of increasing uptake for the first time, HIV testing, treatment, and care among at-risk Nigerian men between the ages of 20 to 34 years who have never been diagnosed or who have been diagnosed but unlinked to care. So the small test pilot was conducted in 2 LGAs in 2 of the RISE implementing states. One LGA in Akwa Ibom called Ikotekpene, and the second in Okoja LGA in Cross River State. This was done for about 6 weeks with campaigns running on Facebook. The desired outcome for the pilot was, to increase the number of men between the ages of 20 to 34 who will be newly diagnosed HIV positive, to increase that yield for that age group in, the Valor, in the RISE implementing states, and to increase enrollment of the same age group into treatment and, link the unlinked men of this age group again, those who have been diagnosed but unlinked to care, to be linked into ART services. RISE has also continued to implement since the initial pilot and has integrated Valor messaging approaches across our HTS services and our treatment program as well. Next slide. So basically, the gap identified on RISE helped us come up, implement the Valor theory, which states that if we use, the human-centered design light approach to develop resonating messages and create concepts for HIV testing through social media that is empathic, that connects to men's deep concerns and desires, we can invite these men virtually to connect to people that can be trusted and people that can relate to them and are knowledgeable about HIV services. This will in turn enable RISE to establish, a network of virtual navigators who can respond to questions around HIV services and testing, and screen these individuals early on in their decision-making process while addressing, their needs and their concerns. In turn, we can then link these men to, community HTS and self-testing services in a way that is very supportive, empathic, and confidential, and then we can actually reach these untested men, unlinked men between the ages of 20 to 34 years and get them tested and linked to care. Next slide, please. So what makes Valor really exceptional is the fact that we're able to learn from a lot of previous projects that targeted men. And we got some key insights about men and, their perceptions around HIV. For example, some of the projects we found, we realized that, men questioned whether, having courage to cope with the positive result was enough for them. Also that men have been traumatized with, images and messages around AIDS, stigma that is attached to it, and, the old treatment regimen. And, men also fear what a positive result might mean, which might mean, they lose what matters most to them, relationship and a sense of feeling strong. Also, previous projects, brought up the notion that, courage for men is focused on brute force. They just need enough courage to take the next step. And most of the messages around positive living for HIV usually comes too late, which is after, a positive diagnosis has been made. So for Valor, what we noticed from this, what we got from these insights were that men, are alone in their fears and feel ashamed. Men also feel isolation is worse than death, and that courage is equal to social support. Having support and love is equals to courage. And men really want to keep what matters to them, which is their love, their family, and a sense of belonging, and sex. And one key insight we got was that men, couldn't relate to, messages that portray that, they indulge in high risky behavior and that they are irresponsible and uncaring. Next slide, please. So the Valor Initiative focuses on engaging men virtually and celebrating them at every step of the way. Valor, simply works this way. A man is avoiding getting tested because he's afraid of a positive result, because he knows he's taking some risk and doesn't want to feel ashamed or lose what matters to him. A Facebook ad pops up on his feed telling him that there's a new HIV treatment, which is no longer a big deal, even if he's positive, and that he can keep what matters most to him. So he believes this ad because he also sees a message about a one pill day treatment, and that he will have a friend that can support him through this process. He feels comfortable enough because he thinks this will also provide a VIP treatment, and he clicks and is linked to a WhatsApp message where he meets a VIP guide who encourages him, answers his questions, and makes him feel brave enough to set up an appointment in a nearby clinic. He's also reassured that, there's a team waiting for him in the site who will support him with the services. After getting those services done, he still connects with this virtual guide who gives him information and supports him irrespective of what the results is. For some men, seeing these ads a couple of times is enough motivation for them to finally get tested. And the Valor ad used an all virtual process, which goes from Facebook to WhatsApp. And most of the insights we got also was done through, a virtual focus group discussions with men between the ages of 20 to 34, so that we could come up with the Valor ads and also the right language, the guides, virtual guides we use when discussing with the clients. Next slide, please. So what is the Valor secret sauce, like we call it? It stemmed out from insights, like I mentioned earlier, from other projects that focused and targeted men, and from the virtual focus group discussion the team held with men between the ages of 20 to 34 years of age. This helped the team develop the Valor approach, which creates inspiring messages that encourage men to make informed decisions about HIV services through social media at their convenience. So the Valor approach basically celebrates courage, promises these men that they will be a trusted friend and a guide who can connect with them and connect with them so they can make the decision to take the next step. Valor also reassures men that their family would still love them and remain safe, irrespective of the results. And for Valor, we meet these men where they are with empathy and understanding. And the Valor approach consistently depicts a loving egalitarian relationship between men and women. Next slide, please. So for the Valor messaging, it's focused on resonating promise and a reason to believe. This message has reached a large number of people with correct, consistent, and accurate information around HIV. And the message hinges on three major themes, which includes claiming courage to get tested, which tells them that they are not alone. They can keep what matters, that means their loved ones can remain with them and remain safe, irrespective of the results, and that they can continue to enjoy life and thrive with the one a day pill as well. It's important to note that during the focus group discussion and the prototype, men consistently asked and requested that, the message depict support, joy, and love rather than, isolated pictures of men, having courage alone to make decisions by brute force. Next slide, please. So after the team work came up with the approach, the next step was capacity building, and the first valor training was conducted with 4 guides, 2 for each LGAs in the state. And this was followed by weekly mentorship sessions on WhatsApp group and one-on-one sessions with the guide to reinforce messaging and lessons learned during the training, to continually align with, to continually have an alignment across both states and with the guides on messages and services to provide across those states, and also to provide feedback and support, and then solve problems together with the team. So this was the first training, and those are the participants and the facilitators in the pictures you have on the right. Next slide, please. So at the end of the pilot, which took about 3 months between October to December in 2020, we were able to reach thousands of men with anti-stigma messages and engage 920 men via WhatsApp. We connected 736 of these men to HIV testing services, of which 48 of these men were identified reactive and linked to care, giving us a yield of 7%. But it is key to note that about half of the VIP clients that were identified were already known positives. So they previously knew their status, but they were unlinked to men. But through Valor and Valor messages, we were able to link these men to services, and they're currently in treatment and care. Next slide, please. So we'll be looking at what we've been able to do post-implementation, the 2 years after the pilot. Next slide, please. So in FY21, that is October 2020 to September 2021, next slide, we were able to build capacity of counselor testers, case managers, and the proprietors of clinical platforms on valor-tailored messaging and counseling as well. This was integrated into prevention training sessions, trainings such as, the index training, the PrEP training, gender training, and HTS training. In the same year, we also developed some materials as well, such as posters, flyers, which were domiciled in areas where men frequently meet and in some of our male lounges in our facilities as well. The same way, we also followed up with men that had reached out to us during the pilot phase, but necessarily didn't get back to us, or who were not linked to HTS services as well. In the same year, we also conducted an assessment just to see the attribution of valor to our treatment, to clients on treatment. And we started conceptualizing the integration of valor into LAMIS Lite, which is our electronic management system on the RISE project. Next slide, please. So this slide briefly shows us the attribution of valor to the overall number of men tested and identified positive during that year. So since the pilot, we've been able to increase the proportion of men 15 years and above that have been identified positive between 39 to 44%, while the numbers of testing had reduced in that same year. Next slide, please. Next slide, please. So we'll be looking at what we've been able to do in FY22, which is between October 2021 to September 2020. So in this year, we continued training individuals, and we also had an in-person training this year. We had a demand creation session where we sat down with a team of the demand creation team to come up with other materials and content which we've been able to use on social media and in places where men frequent as well. We've also been able to successfully refine, the SI monitoring and evaluation approach by integrating value attributed questions to our LAMIS Lite system, that's our electronic monitoring system on RISE, and have trained case managers and counselor testers on how to use that. In the same way, we've also been able to expand Valor via WhatsApp and Facebook, and are now transitioning to, handling these platforms by ourselves, by the in-house team. And we've been able to also optimize HTS testing through Valor ads as well, and have included Valor ads to our WhatsApp display pictures for Valor optimizers across our states. Next slide, please. So this is a snapshot of the training and the team that participated in the training in this year. It was an in-person training where 23 Valor guides participated. And the focus was again on reinforcing the message, what Valor is all about, realigning the message and ensuring that the whole team are using the same message and using the same approach to achieving our set goals as well. A key outcome from this training was the team was able to build capacity on documentation and the use of the documentation tool. Next slide, please. So this is a snapshot of the integrated approach. In FY22, we also strengthened the ability for us to be able to reach more men who necessarily might not be able to hear about Valor, hear about HTS services on social media. So we have pictures of, the Valor guides talking about Valor in the male lounge in one of the communities. We have the radio talk show where we talked about Valor, messages around Valor and HTS services for men, and also dropped contact details of our Valor guides, to which individuals have reached out to them on WhatsApp and on Facebook and on via phone calls as well. Next slide. So here, this slide shows our reach on social media. We currently have 1 Instagram page and 6 Facebook pages, 1 for each state and then 1 for Valor Nigeria. We post content across these social media platforms on a daily basis between 5 p.m. to 7 p.m., which is a peak period. And that is done between Mondays and Fridays. And then we repost again on Saturdays. This platform provides an opportunity to attend to questions, requests, and inquiries that are made by individuals who reach us there. If you could see on the third picture that's displayed there, we've been able to reach our target audience, which ranges from ages 18 to 34, and they account for about 2/3 of the individuals who viewed the page and made inquiries on the services. Next slide, please. So this is our performance this year, between the period 52 days where we're able to engage a social media consultant. We were able to reactivate or activate the Instagram page and the Facebook page. On the Facebook page, we started off with 81 active followers at the beginning, but towards the end, we had 133 engaging members. On Facebook, during the downtime, when we're able to reactivate it, we were able to identify individuals who had reached to make inquiries about HTS services. We're able to reach those individuals and link them to services. So between the 52 days, we were able to put up 52 posts, and we got impressions that individuals that looked at that clicked at one particular at a particular point in the page or on the Facebook page, we had 214 individuals that came to the page and looked at what the ads were. We got 50 clicks, that is 50 individuals that actually clicked to be linked to a virtual guide on WhatsApp. And we had 456 individuals who saw the pop-up and just looked at what the ads were on that page, and were able to link 40 of these individuals and refer these 40 to the virtual guides for HTF services. Next slide, please. This slide just simply depicts a conversation on Facebook and WhatsApp where the VIP clients reach out to make inquiries around what Valor is about, what services they can get as well. And, also conversations where they're being encouraged, to take the next step to know their status. Next slide. So at the end of this COP year, we were able to engage 16,395 men via WhatsApp and Facebook. We connected 8,227 of these men to HTS services, of which we were able to identify 334 of these men as reactive and linked all 334 to ART services, giving us a yield of 4%. I think it's critical for us to mention that when you compare this yield to the overall RISE yield of men ages 15 and above that we identified positive, we had a 2.6% yield, while Valor gave us a percentage of a yield of 4%. So in total, Valor contributed 5.3% to the total 15 years plus men that were newly enrolled on treatment this year. Next slide, please. This just depicts the contribution of the states, looking at our performance by state, with Akwa Ibom giving us the highest number of people that engaged with the virtual guides that were linked to HTS services and were identified reactive and linked to care. Next slide, please. Another key win for us this year is how we've enhanced and improved on our monitoring and evaluation approach for Valor. This year, we've been able to improve our daily reporting and data review meetings. We have meetings on a daily basis to look at what the trends are, to fix gaps and issues that are identified, and to provide support to the team on ground. Most recently this year, like I had mentioned earlier, we've been able to integrate Valor into the RISE electronic data management system, LAMIS Lite, so we can begin to measure and attribute Valor to the HIV program on RISE. And we've been able to successfully develop our Valor e-register and indicators this year. Next slide, please. So the RISE team are aware that there are a lot of interventions targeting men. And so we decided to conduct an assessment amongst our clients to find out those who have seen an HIV prevention message on social media, and in particularly a message about Valor, and if that message influenced them seeking support. When we conducted that assessment, of the 44, when the assessment was conducted, it revealed that 44% of the newly enrolled clients who responded to this assessment mentioned that they had seen the Valor ad, and that influenced their decision to get tested and to get support for other HIV services on the RISE project. Next slide, please. So this is a sample of our indicators, which also came out from the training we had this year, what we'll be reporting going forward as well. Next slide, please. We've come a long way on RISE, and we've learned a lot and improved on our performance and our service delivery based on challenges that we faced during the pilot phase as well. One of such challenges was, that Valor was only limited to individuals that had Android phones that were on Facebook and WhatsApp. Also that, the valor message on social media reached individuals that were outside RISE's supported locations, and that we were able to provide, we're in a position to provide, optimal services to those individuals that were within the RISE catchment areas in the supported states and LGAs. Also, social media downtime and glitch slow down our activities, which reduced linkage to virtual support for individuals that reached us on social media. And another key challenge we had was the issue around insecurity in areas where we had men, where safety was an issue, and being able to link them up to services in our facilities, especially facilities that were far off, was a challenge that we faced at the onset. Next slide, please. Based on that, based on the learnings and the challenges, we as a team got some key takeaways, and some of those things we'd like to share with you. Because of Valor, we noticed the testing coverage amongst men, men that were identified positive, and the uptake of PrEP had increased on the RISE project, especially with the integration of Valor to HIV services. Also, self-testing and other HIV services have become more acceptable amongst men using this platform that focused on providing support to men, both virtually and in person as well. Also, the mixed virtual and in-person approach has helped Valor to expand our messages and our services beyond social media platform. We're able to reach more people in the community and across the different states we implement. Valor also, provides, an opportunity for men to have a sense of autonomy and, own the responsibility of taking care of their own health, because it provides an option for them to, an opportunity for them to schedule their own appointments, which was necessarily not the case, in facility, when individuals had to go to facility to access services as well. For us also, WhatsApp remains the most important and most used medium for our Valor campaign, because of the sense of privacy and confidentiality it provides to these men as well. And beyond the numeric achievements, Valor has been instrumental in changing perceptions and correcting misconceptions around HIV, services and treatment as well. And it has become more desirable now due to the message that goes out on Valor, about Valor and HIV services. Next slide, please. So for the team, our next steps and in areas we hope to expand on this coming year, we started conceptualizing, working on a concept on an automated system for, reaching our clients, linking our clients to our virtual guides, and also, an automated tool for data collection as well. So we started the concept with the SI team, and it's something we're hoping we can work on, finalize this year and deploy as well. This year, we'll also continue to develop demand creation content, which we'll put on our social media platform and the other platforms that we use on RISE as well. And we started talks on compiling the referral directories, not only on the RISE, not only in the RISE implementing state, but outside, so that when individuals outside the RISE implementing states reach us, we are able to refer these individuals to services in the localities where they reach out from. Next slide, please. So this is a quick testimonial that we got on our Instagram page of 3 individuals, one from Adamawa, Cross River, and Akwa Ibom State. The first testimonial talks about an individual that's Mr. George, who had been ill for a while, but had not gone to seek services in the facility. But he stumbled on our Valor message on Facebook and was able to engage a Valor guide who was friendly and provided him with information around HIV and HIV testing. And he was encouraged to make go ahead and get tested. He was identified reactive, but has been enrolled on treatment and is still on treatment because of Valor. He also continues to engage with our Valor guides, who continue to provide support to him as well. We also have Christopher in Cross River, who talked about seeing Valor ad again on Facebook, and who was engaged with the guide who, gave him information around HIV and, was able to refer him to a facility close by where he got tested. The great thing about this is that he talked about the Valor guide, supporting him and removing, allaying all his fears, even if his results would be eventually positive. He talked about how Valor, gave him the power and the support to actually go ahead to know his status, his HIV status. And the last testimonial, which is one of my favorite, talks about a man who was engaged by our Valor guides in a bar, in one of the local bars, in one of our LGAs. This man talked about the fact that he'd been worried because his wife just recently got diagnosed positive and was on treatment, but he was afraid to go and get a test because of what the result might be. But with the engagement of the Valor guides, he was educated on PrEP and on HTS services, and he was encouraged to know his status. He talked about how Valor, it's like a school in the 21st century, which supports men to take care of their health and provides education about HIV services. Some of these testimonials, we can also see them on our Instagram page. These are just a few of the testimonials that were shared with us on the Instagram page. Next slide, please. So this picture depicts one of our outreaches where the Valor guide was talking to a group of bikers. We like to call this the Valor drive-by, educating them around condoms and, talking to them. They can always about what Valor is all about, and I talked about, the HIV services. You can get more information on our website, which is risevalor.org. Or you can also look at our Instagram page or the Facebook page. The details are here on the slide. Next slide, please. Thank you very much. Over to you, Ruby.
Thank you, Ehi, for that really stimulating presentation on using human-centered design approaches to engage men in HIV services. We have some questions that have come in through the Q&A. Please type your questions over there and we will get to them. So maybe let's start up with the first couple of questions. Someone is asking that, was there a national campaign for the Valor project? And they're also asking if there was any collaboration with other implementing partners on the Valor project.
Okay, thank you for that question. So Valor was an initiative and it came into being. We started it up as a pilot and we implemented in 2 states. So it was something that we were conceptualizing and we wanted to try. And based on the success rate, then it could be something that could be, probably shared and probably scaled up across the nation. So it was just a tiny pilot that was implemented in 2 states within the RISE project and the RISE team as well.
Thank you. We have another person who's asking, how about using a mobile app for HIV service directory for those who are insecure about engaging in online social media? Is this something you've thought about?
We actually thought about it, but so Valor is something that we're building as we're going, because there are a lot of things we're learning along the way, and I think that would be a great great add-on in terms of referral to states outside RISE catchment area as well. Thank you for that suggestion and that question. Thank you.
So we have another participant who's asking about how we can ensure the integrity of the HIV results for the Valor men. Maybe you can describe what happens. So once they agree to get tested, what's the process in terms of them getting an actual HIV test and then verification before ART initiation?
Sorry, I didn't get the question. Sorry, please.
So the question is around the integrity of HIV results for Valor, men. And I'm saying maybe what you can explain is once someone has seen the message and hooks up with a Valor champion and agrees to get tested, where is the testing occurring? And once they have a positive test, how are they linked to services and what is done around verification testing before ART initiation?
Thank you. Thank you.
Oh, go ahead.
Yeah, okay. Thank you. So, like what I mentioned earlier on, so an individual clicks from the Facebook page and is linked to one virtual guide who he asks questions around what Valor is, what are the HTS services, which include condoms, PrEP as well. And when this individual is convinced or has reached a level where he feels confident enough to get tested, the virtual guide links him up or refers him to a facility that is close by or to a clinical platform, because we have platforms also in the community where he gets tested. We now have a Valor team in-house in the facility, for example, who are waiting for this individual, and this individual just needs to go in there and mention that he's been referred to by Valor guide. This individual is then tested, and then based on the results, is linked to care. But he continues to have communications, discussions with the virtual guide, who provides him support on the necessary services he would require. So that's what we do as well.
Thank you. So another question that has come in is around continuity of care and continuity of treatment for those who are engaged in HIV services through the Valor program. Do you have any data on their continuity in treatment compared to the RISE data?
Okay, so that's a new innovation. I mentioned this on one of our slides, that one of the things we've done this year is to firm up, integrate Valor into the RISE electronic monitoring system, so that we can begin to identify attributions of Valor to the overall HIV program on RISE. So this year, we're believing we'll be able to see that attribution to the project.
Thank you.
Yeah.
So another question is the WhatsApp video call. Is it envisaged for more interpersonal communication? Is this through groups? And do you have to actually smaller WhatsApp groups over time? Maybe you can explain a little more what happens in the WhatsApp groups.
Okay, so there are two things. The WhatsApp group I mentioned was when we had the focus group discussion, when we're developing content and messages and ads for the social media platform. But in terms of services, an individual is linked to a guide, and that is the person they interact with for privacy and confidentiality. So we don't have a support group or a group when it comes to service delivery or getting information about what services we provide. So those are the two instances where we use WhatsApp. So the WhatsApp group had to do with the focus group discussion at the onset of content development. But in terms of services, like I mentioned, it is a one-on-one session with the virtual guide and the VIP client I hope that answers the question. Thank you.
Great. Another question is asking about reaching men such as the clergy or politicians or other people with high profiles who typically do not want to come to the health facility. Has it been possible to use the VALA approach to reach these men since they suffer silently or seek care in private institutions in secrecy?
Thank you very much. That's a great question. So I would like to also mention that outside VALO, we've had other male finding strategies. We have the DSD model on RISE, where individuals are provided services based on their convenience. And one of those services is home visit. So in a situation where a client asks for services to be brought to them, we do that. And we also try to adopt that on VALO as well. So we try to make service provision as convenient as possible to individuals as well. And one of the strategies we had started working on in terms of ART services was, including the clergy in the service delivery, in creating awareness around HIV in the community. We work with the traditional leaders and religious leaders in most of our states and LGs. Akwa Ibom is a great example of where we have great partnership with the traditional and religious leaders to implement our strategies and implement rights activities. Over.
Thank you.
Yeah.
Another question that has come in is asking if you've thought about integrating HIV self-testing into the VALA project. So this would reduce the need to actually go into a health facility to be tested.
Yes, that is one of the key takeaways, one of the learnings and what we added this year. In fact, it started from FY21, where we also talked about self-testing kits and services, and the VALO guides do provide these options along with PrEP, talking about the use of condoms as well, as they talk to them about other HTS services and other HIV services as well. So that's also included in the package of care that we discuss, or the menu that we provide to the VIP clients as well. Thank you.
Great. So maybe you can talk a little more about how you measure the impact of your messages on social media. Someone is asking, I know you had a slide on that. Maybe you can just elaborate a little more on how you're able to do that.
Okay. So what we have on social media, we have the content that we post on the platforms, either Instagram or Facebook, but Facebook seems to be more active. And based on that, individuals reach out. They go in there, they see an ad, and someone becomes inquisitive and wants to know what this ad is about. What does it mean by one appeal day? What does it mean by, we have services that we can bring to you, or we have someone that you can talk to or speak to about HIV? And then they click on the link. From there, they are directed to an individual who chats with them. That is on the social media. You can chat with them on Facebook, ask your questions, ask for where you can get services, and then you are linked to a facility. If a facility is close to you, or if you want the option of reaching out to somebody in one of our community platforms, that is also made available to you. And then from there, you can actually get services and decide to continue with the facility, or decide to continue with the virtual guides to get services to you. So that is how it typically works. You see an ad, you click, and then you are linked to someone where you can make inquiries and get referred to services. Okay, I'll quickly want to just mention, sorry, Ruby. So because of the glitch we had with social media, we had issues around connectivity and downtime. The team, the great team from the states and the LG thought of an innovative way where we can also continue to pass on these messages. And one of the new things we did, outside having flyers and posters in areas where men reach, we had some of these ads put up on the VALO on the Valor phones, put up on their WhatsApp display pictures. And we've also had people that, make inquiries from there through that platform, chat up with the Valor guides about services, and I have also been linked to care as well. So those are some of the ways we went around the issues when the server, or we had the downtime with social media platform, with Facebook and Instagram as well. Thank you.
Thanks. So another question has come in. Someone wants you to, again, just go over how you were able to engage the men to give you insights that informed Valor. So initially, how were you able to get that information from the men that you used to inform the program using your human-centered design? And then the second part of the question from this attendee is that, since this is a homegrown Nigerian model, are you open to collaboration beyond to other countries?
Okay. Thank you very much for that question. So the human-centered design approach we thought to get a human face, identify what will work best for this target group. And the team, also with those from Jabaigo HQ, thought of coming up with a focus group discussion with men from the age group that we're targeting for this message. We are able to, because of COVID, we didn't have an in-person focus group discussion. It was also virtual. We did it on Facebook, where we had men between the ages of 20 to 34 years, where we asked them about what kind of messages they would like to hear. We also had content that we had developed prior to these engagements and shared with them, got their thoughts about it. They also made suggestions of what they felt what they felt men would want to hear, and that informed the content that we developed and the ads that were made at the end of the day and put up on social media platforms. So everything was centered around the age group the men were targeting, and that informed the kind of message they would like to hear, the message that will resonate with them, and also the language that the virtual guides will use when discussing with these VIP clients as well. Thank you.
The second part of the question is around collaborating with others to implement this in other countries. If you want to speak to that, that would be helpful. Thank you.
Yeah, so Valor has been a great innovation, and we've seen traction even with the little time we've been able to implement it. The hope for Valor, I believe, is not just for RISE and not just for Nigeria. I believe it's a great strategy that will help us reach these men, knowing, the issues around masculinity worldwide, and, how men are being told to man up and just face challenges. This approach, looks at them, sees their fears, their concerns, and are able to support them to, know their status and take better care of their health. So I believe this transcends Nigeria, transcends RISE, and collaborations. I believe management and our leaders or our donors are also already looking at how we can expand that to other regions and other countries as well. Thank you.
Great. So one other question for you is, this started virtually and now you've integrated a community aspect to it. Can you describe a little more in detail what exactly happens around the community bit? You talked about these drive-bys, etc. What else are you doing in the community?
Thank you. Okay, so basically, what we have is we have posters, we have flyers that are domiciled where men frequent. We had a testimonial of someone who was reached at a local bar. Some of these flyers are also put up in our male lounges, where there's a message on Valor, claiming your Valor, or you can reach out to somebody to know more about HIV, and numbers of our VIP guides are there, who they can then reach via WhatsApp or phone call. to make inquiries, more inquiries about services, and to get support or referrals to where they can get tested, and to have other services as well. So the focus is that we first of all identify hotspots where men are, and then based on that, we've developed and continue to develop demand creation materials, which sparks their interest. And in those materials, we have contact details for which these individuals can reach out to and be linked to our virtual guides as well, for in-facility services or for services that we provide in the community, depending on what their preference really is. So that's what we've been able to integrate. And the main focus, why we were able to do this, was to address the issues around downtime on social media, for instance, an issue around data, or for issues around individuals that do not necessarily have Android phones to be with. So we said, why don't we expand it to be able to reach men that necessarily don't, might be in this age group, but might not necessarily fit the criteria, or might not be able to access information on social media. And that's where that stemmed out from. So those are the services we provide. PrEP, again, is there. Condoms are available, HTS testing services. And then for those that are on treatment, the option of also, engaging with a virtual guide for support outside facility support or facility services. Thank you very much. Over.
So another question that has come in is, Valor only for men? What if a woman reached out? How would you be able to support them?
Okay, great question. This has come up, times and times again, even within the group, within the team. And for us, yes, it targets men. But if we looked at one of the slides, the one that showing the reach, we could see that women too also made inquiry. As long as you reach out to get information, we are obligated, and we will provide our support for you to reach service, to get services also, irrespective of your gender. But this targeted men because of the issues we had, and in light of COVID, it was a concept that came up about that time, but it has expanded to that. And, anybody that reaches out is provided services, supported to get the needed services they inquire about. Thank you.
Great, thank you very much. So I realized that there were a couple of questions which came in for Dr. Remi that we weren't able to answer. So I will give Dr. Remi a chance to answer 2 questions still, since we still have some time. Dr. Remi, so what is your advice in the face of insufficient human resources, physicians and nurses who can take care of patients with advanced HIV disease in places which are very rural? What would you advise programs do? The second question is, what is the role of the community health care system in management patients with advanced HIV disease?
Okay, so thank you so much, Dr. Ruby, and thank you for the questions. For facilities or for teams working in a rural setting that have little or no access to comprehensive AHD, vis-a-vis the human resource and the commodities, I will advise them, because that's similar to what we even do in terms of hub and spoke. First is to be sure that we have healthcare workers that have been trained for an AHD implementation. They need to have AHD team. They need to have AHD team. If they don't have a doctor, they need to have a nurse as a part of the team. They need to also have other cadre of staff like pharmacy, M&E, or focal person. And if they don't have all these, at least it would be nice for them to have a nurse and have counselor tester that can actually test clients, and have case managers, which can actually be any cadre of staff, but at least be able to own the client and actually serve as treatment support specialists and know the AHD cascade of care. And it's important as well too that they know the package of care, and also identify a facility close by that will serve as a hub facility, and to probably also know the level of health services that the hub site can render. Vis-a-vis is there availability for specialists to perform the lumbar puncture? Do they have a facility for cold chain monitor for the liposomal and thyroxine B, and availability of opportunistic drugs? So they need to know that, probably have the contact, so that they will serve as spoke sites to these hub sites, so that if they can actually handle out of the 4, they can screen and know that this client is positive, or among the clients that have been that were lost to follow over a year, and they track this client back. They can also screen this client, and also for clients that have persistent viremia, they can also ensure that they screen these clients with VisiTech. So it's important for them to have VisiTech, because that can be done, that can be used at the community. And TB Lamb is something that they can also do, because it's a point of care testing tool, and even at the community. So that for those who probably now need, also serum crack too is something they can do, because they can be trained and they have job aid. And if they need to make further diagnosis or confirmation for critical meningitis, then they will need to utilize the hub and spoke to have an expertise who will actually get the lumbar puncture done, or also working according to the guidelines. So that is very important. So because it's just like what I said, we have about 31 hub sites and about 74 spoke sites. So even if when you have the capacity at the spokes, you need to also ensure that you have the lumbar, the spinal needle. You need to have free where you can keep the liposomal and thyroxine B, to mention but a few. And for the community ART team, on the RISE project, we have, like for our hub site, we support 101 facilities currently, and about 31 of them are hub sites. And these hub sites are sites where we have the community ART team. We actually call them tech team, tactical epidemic control. And these are teams that comprise of, across the 395, a counselor tester who screens the client, and after screening the client with serial algorithm, the case manager also in the team ensures that there's retesting. Then we have a data entry clerk that supports with the data entry and management. There's also a pharmacy in that hub as well, to ensure that availability of this OI drug, and also we're ensuring that they use the needed payment form for commodity forecasting and logistics. And they have a tech team lead, a nurse. The nurse works with them at the community. He or she helps in carrying out clinical review, because it's important for every client to be clinically reviewed using either the adult or pediatric initial clinical evaluation form. So it's called an ACE form, where they will capture the staging, WHO staging, that's stage 3 or stage 4, and it's like taking a detailed history of the clients, and the client will sign, they will also sign, and it's the payment form that is filed in the client's folder. So having this team will working together, and as new client comes in, as client that track back and the like, and supporting them with the point of care tool that can be used by everyone. So imagine, it's only lab scientists that can use the BD Fast Press tool that are located at the facility. But a VisiTech, anyone trained can use a VisiTech. Anyone trained can use a TB Lab. Anyone trained can also use the serum crack test, while subsequent confirmation and like can be done at higher facilities. So community ART team, the feasibility of it is sure, because that's exactly what we do. And we're leveraging on a tactical epidemic team, and ensuring that at the community, whenever a client is saying, and they've done the level of assessment and screening to an extent, where there's need for escorts and linkage, they do that to the hub facility and here. So I hope that answered the question. Thank you.
Thank you very much, Dr. Remi. So I'd like to thank our presenters, Remi and Ehi, for sharing with us lessons learned in implementing services for recipients of care with advanced HIV disease in Nigeria, and improving HIV testing and linkage for men using the VIALA approach. I'd like to invite the Global RISE Director, Kelly Curran, to close the session. Thank you very much.
Thank you so much, Ruby, and thank you, Remi and Ehi, for this great presentations. Most of all, I would love to thank the very engaged participants in this session. I've been so pleased to see that at one point we had nearly 200 participants, and I've really appreciated the very thoughtful and thought-provoking questions that you've asked in the chat and in the Q&A. I think the questions that have been asked of our team will only make our programs stronger. So thank you very much. I'd also like to thank our colleagues at USAID who both provide funding for our work, but also provide technical and programmatic guidance and support. And of course, the Ministry of Health of Nigeria support at the state levels and the frontline healthcare workers and the recipients of care who are the backbone of this program and the reason that we do this work. So thank you to everyone for a great session. I think we'll be able to close just a few minutes early. And again, to the wonderful participants, we really appreciate you spending 2 hours out of your very busy schedule to join us today.